Welcome to the NEI podcast. This is Dr. Sabrina Siegel, and I have here with me our guest, Dr. Rona Hu, and we are discussing National Minority Mental Health Awareness Month. I'd love to ask you, we've talked before about how there are many different types of stigmas that surround mental health issues, and that there tend to be cultural differences or biases regarding this. And also, there are communication and language barriers that might make the issue of mental health even more challenging for minorities. Do you think that you could speak to this and just share your thoughts with us about that?
Yeah, I think you ask a couple of very good questions, one of which is about stigma and also about some of the communication and language barriers. So, starting with stigma, I think that in American culture, mainstream American culture, there is some stigma against mental illness, but that's changing. And I think that there is even more of a stigma in a lot of minority communities. Immigrants coming from different countries, for example, often have the same attitudes that were pervasive in that country. So there can be this idea that mental illness is a moral failing or a weakness, and that makes the stigma that much more. They may feel like mental illness is not something that can be treated. Cultures that feel like mental illness is a shame, they may feel that the shame affects the whole family. So I've been told by some patients' families, oh, we can't acknowledge that this is happening because then his sister wouldn't be marriageable. Or, even people who have relatives that are in the medical community, either in the home country or in the United States, they might say, oh, well, they wouldn't trust this family member as being a doctor if it comes out that they have a family member that has a mental illness. So I think that that is something that is sometimes surprising to people in mainstream American culture, is how the stigma of some groups is really above and beyond what already American mainstream culture stigma against mental illness is.
What do you think that people could do, just sort of the general public, in terms of being more aware of minority mental health issues? So I guess that question refers to really, what do you think the general population can do to sort of help with that situation? And then also, what do you think clinicians could do to help with just becoming more aware of the particular challenges that minorities face with mental health issues?
I think the general public has a number of challenges in helping everyone get proper mental health care, but also specifically minorities. Realizing that you sometimes have to reach out a little bit more and really make it okay for someone to get help. So, in younger people, there's been campaigns to sort of say it's okay to not be okay, that asking for help is not a weakness, that actually knowing when to ask for help and getting help and accepting help, that that's actually a strength. That's something that we can all do better on.
Yeah, I agree. So, in terms of just minority mental health challenges, you think just being more aware of cultural differences, would help this situation?
And helping address some of the disparities in general that minorities can face. I think, what do they say for the TSA people? If you see something, say something. I think that's even a better motto for mental health is, you hear a lot of these tragedies sometimes in the news where someone who really needed mental health help didn't get it. And a lot of times, people, neighbors, schools may have noticed something and didn't feel empowered to say something. And so, something where they can offer just some encouragement. It's like, hey, I notice you seem really down lately, or wow, that must have been really stressful when this traumatic event happened, something where they reach out And if the person who's reaching out is in the minority community, it can be something of saying, hey, this is something that we all struggle with sometimes. I think that there is help available, and I'll help you out with that. People who
Mm,
are not in the same community as the person they're reaching out to might feel hesitant, but a lot of times something that's phrased in a very sympathetic and non-judgmental way can go a long way. And so if they say, hey, a lot of people would feel really stressed out by what you've been going through, and then just let them know that they're not being judged.
one of the great challenges for minorities is just basically not being able to receive adequate mental health care for various reasons, some being financial, and things like that. So, not only do we need to ensure that minorities receive adequate mental health care, but we also have to make sure that we have trained health professionals that are also culturally equipped. So, meaning that they are empathetic, they're non judgmental, they understand the culture, and they can relate and communicate properly to diagnose patients who walk into their office. What do you think you can say to this issue of just being culturally competent as a clinician? I know that you've done some work on cultural competence and you've lectured on this topic before. Is there anything that you can share with us in terms of this very important topic?
It's a big topic. I have lots of specific little tips. Obviously, this could take way more time than we have, but some things in being culturally informed is to give yourself permission to ask questions and to clarify, and then realizing that some of the assumptions that you might have aren't ones that are shared by the patient. So, for example, um, in terms of even asking questions, there's many cultures where it's disrespectful to ask an authority figure questions. And so in Chinese, for example, the sentence 有没有问题 means both are there any questions, but it also means are there any problems? And so a default answer that many patients will have is like, no questions, which also means no problems. And so they might actually be thinking, well, I wonder if this medication is going to give me terrible side effects. And so in some groups, challenging the doctor and say, well, wait, I heard about on a talk show that this medication will, make me, this medication will kill me or something like that. And
Mhm.
I found that with some groups of patients, they'll just come out and say that. But with some groups of patients, they've seen the same talk shows or they've heard rumors, but they won't come out and ask. So I think one thing to sort of realize is that when you've asked them about, do they have any questions, and they don't say no, don't just take that as being the real answer. You can
Mm,
give them permission to ask questions by saying, well, some people will have questions about whether this medication has side effects, or some people have asked me if I need to keep taking this medication and for how long. So there can be misunderstandings that you don't know to clarify until you've asked a couple of more questions. There's um, there's a lot of ways in which you can help in terms of compliance is a big issue, adherence or compliance.
mhm.
There's patients who are there's patients who won't take medications for a variety of reasons, and
Right.
when this happens, for example, I've quoted before in some of the talks that we've given that when they did a study in 1989 at a refugee clinic with Asian refugees, 61% had no detectable level of antidepressant in their bloodstream, and another 24%, I think, had very low levels. So a full 85% had either no levels or very low levels of medication in their bloodstream. And a nice part about the study was that they then asked the patients, wait, are these people who just had very quick metabolism? What was the matter? And the patients admitted that they hadn't taken the medication for various reasons, but they hadn't felt emboldened enough to ask their healthcare provider. So things that you can do when a patient comes back to the next appointment and say, so how's the medication? Do you have any side effects? Or do you notice any difference? And if they just sort of say, oh, no side effects, not to just sort of take that as being, okay, that means everything's fine. You can ask, well, sometimes patients find that the copay was more than they anticipated. Is that something that happened? Did you consider taking the medication and saving some of it? Oh, so you can say, did you consider taking the prescription and setting it aside and saving it for another time? So that's a little bit of a face-saving maneuver so that it doesn't seem like they're defying you, right? Or you can say, the some patients take this medication and they get a side effect and they decide to save the rest of them to later. Did you think of that? And the patient says, yeah, I thought of that. And said, did you go ahead and do that? So that sort of softens the blow of potentially defying you in some way, and then really making it okay and say, well, I ended up not filling the prescription because it cost too much. And then at that point, praising them for bringing it up with you. Like, I'm so glad you mentioned that to me. Well, let's figure out how that would help. So you mentioned financial difficulties for some patients. That is something that clinicians should keep in mind for all patients, but it'll come up more for some groups where they don't have, you know, they don't have as much access to care. So if you can write a prescription that has all of the medication in one bottle. So, for example, if you were going to write for 275 milligrams of something and it requires one bottle of 200 milligram tablets and a bottle of 325 milligram tablets per day, the patient's going to be charged two copays, and it's also going to be very confusing. If you say take one of these and three of these, sooner or later they're going to take three of one and one of the other. So, so really checking with them what's affordable, and a lot of people, particularly in minority groups, might feel ashamed that they can't afford it, and so they just won't bring it up. But if you're able to ask and work with them around, this medication comes in two forms. One of them is going to be a lot less expensive. Why don't we try that? That's something that might be a good way to do it. You also mentioned communication issues, and the verbal and nonverbal communication for a lot of groups is going to be different than mainstream American culture. In the mental status exam for psychiatry, they often say whether eye contact is good, fair, or poor. But in some groups, you really aren't supposed to look directly at the clinician. Especially if the clinician is the other gender. But sometimes, if you're perceived as being from different social classes and you're an authority figure, some patients won't want to look at you. And so you may interpret that as being poor eye contact, but for that patient, it's a sign of respect. There's a lot of different nonverbal things. Since this is a radio podcast, I can't, show you. But in South Asian culture, there's sort of what looks like a head shake, but it's sort of a semi-nod. It's sort of a head bobble, which kind of means yes. But I've seen clinicians who aren't familiar with that believe that the patient is shaking their head, and they're actually sort of agreeing with the physician, or it's kind of a guarded yes. One story that I've told lots of times about nonverbal communication wasn't even in a psychiatric setting. This was when I was a medical student at a San Francisco hospital where they had lots of Asian patients. And an OBGYN resident told me that Asian women needed less pain medication. Or no, I think he said Asian women feel less pain. And I
Wow.
thought, wow, that's really news to me because I'm an Asian woman. And then the next Chinese mom who went into labor went, and so he said, "What's that tongue clicking thing they always do?" And I said, "That's pain." But he was unfamiliar with that particular cultural expression of pain. Some groups will feel more able to express themselves when they're in distress. Some cultures really aren't supposed to. Um, and, you know, the the loudness with which someone expresses something is going to be different in different cultures, and then the intensity of their affect. Um, there's been lots of research showing that people from one culture are often not as good at interpreting facial expressions from another culture. So if you don't have as much familiarity with the patient's particular culture, you might have to work a little bit extra to try to see how they really are doing, because they might not tell you, and their expression might be pretty different. The words that people use are going to be different from culture to culture. So some of this might be in someone who's not a native English speaker. Some of it is in people who have grown up speaking English, but in their particular group will say something a little bit differently. So, sexual topics, somebody might use euphemisms. So use the term like, oh, it's my nature,
Right.
instead of saying, I'm worried about erectile dysfunction. Because the term erectile dysfunction isn't something that everyone's going to feel comfortable with. Um, I mean, there's so many examples of this in lots of different cultures where
Mm.
something will get misinterpreted. There's definitely cultures where they'll particularly minimize something because it's not polite to say it very strongly. A resident just sent me an interesting link to a Malcolm Gladwell book about the book Outliers, and how the he had very interesting things about how Korean Airlines had a very high accident record until they switched their pilots over to speaking English. So native Korean speaking pilots weren't communicating with each other well because they had been raised to be so respectful. The first officer wouldn't say with much urgency to the pilot how much. So they would say, oh, I'm so grateful for the existence of radar, rather than, Captain, you got to look at the radar, or the weather is very bad, instead of, this is really dangerous weather. We should probably try to land. And so it really took serious retraining for them to be able to communicate more directly. And then once they did this, their accident record, um, you know, became much better, and they became one of the safest airlines. But before that, the
Wow.
the flight recordings that they had on some of these accidents found that right before the accident happened, the person who detected that there was a problem couldn't communicate the urgency nearly as well. So it would be understandable if it's happening between a pilot and a co-pilot, that between a patient and someone from another culture, they might be hesitant to say how worried they are about something. We sometimes prefer to use the term culturally informed instead of culturally competent, um, because it's more of an ongoing process rather than a destination that we sort of reach. And then people don't feel bad if they need more information. We don't want to imply that somebody's culturally incompetent.
Right.